We shall now go on to another interesting video to be shown by Dr. ANJUM MAZHARI, who is a senior consultant at Indira Gandhi Eye Hospital and Research Center at Lucknow. So on to you, Dr. ANJUM.
25-year-old male reported to us with history of injury in his left eye by a
Can you hear my voice also? Voice
Yes,
cover.
yes.
Yeah.
He had a partially healed non-communicating corneal tear with anterior capsular rupture and traumatic cataract. The tear was seeded negative. Lateral extension of anterior capsule rupture was not visible in maximum dilated eye. B scan was normal. Finding the other parameters of anterior chamber and vitreous cavity normal, phacoemulsification with foldable IOL was planned. SICS tray was kept ready. Anterior capsular rhexis is started and completed in a very controlled way. Emulsification was performed with modified parameters. Gentle irrigation and aspiration at right angle of the tear was done to avoid anterior capsular extension. Foldable IOL was first released in anterior chamber and then pushed into the bag to avoid push and pull during implantation. During positioning of IOL, dialing was avoided. After completing the phaco steps, sutures were applied to repair the corneal tear. The case was evaluated for result during post-operative period. At 3 months, all sutures were removed and visual acuity comes to 20 by 20. Thank you.
Thank you very much, Dr. ANJUM. That was a very nice video, but we would want to have some questions here. Now, this is a traumatic cataract repair with an ALC tear. So I would want our expert panel, maybe I would start with Dr. Ajay. What would your treatment algorithm be for a traumatic cataract with a corneal tear repair? When and what?
Most of time when we are not sure about the...
No, okay. Yes.
Yeah. So we planned a manual SICS. We do the tear repair first, then if needed, we do the cataract at the same time. And if we feel the iris is very much traumatic also, then we wait for the next, after 1 month or 1.5 months, we do the iris repair also and do the cataract surgery. But in this case, only one thing was abnormal, the capsular extension. The extension was not visible to our eye. So upon finding the B scan normal, we have kept both the SICS and phaco things ready, but we thought we should, this was the 4th case of that traumatic a corneal tear for me. So I thought whether to proceed for phaco.
No, but I believe that if you have a traumatic cataract with a corneal tear, you would deal with the corneal tear unless there has been some kind of a lens damage and there is lens matter in the AC. You would do the corneal tear repair and then wait. Even if there is cataract, you could wait for the cornea to stabilize, do a more accurate biometry, and then do an IOL in a second sitting. Is what I would believe. I want the experts' opinion on
I
that.
agree with you, but one thing was anterior capsular rupture was there. So we thought the removing the cataract at the same time also. And that case was CDL negative. So we thought ki first do the phaco, then for a good visibility, then put the sutures of the tear.
Yes, Dr. Ajay Paul?
I think what he has done, because the corneal tear had sealed. So in
Yes.
that way, he was right in doing whatever.
Yes.
But normally, as you said, if there are a lot of fluffy matter and all, unless they are not there, we just suture the cornea, wait for the eye to settle, even if there is a penetrating, as long as there is no chance of any inflammation and all. And if it is there already inflammation, obviously remove the lens and do the under. Many a times, if the tear is too much, we cannot do the biometry. Normally, we do the other eye biometry and see and think if I have to do it in primary procedure.
When would you
try to put it in a secondary procedure?
Yeah, but he has done a hydro dissection. I don't know whether any of you have noticed. For an
He did a
anti-capsular
hydro
tear,
dissection. There was
maybe
always a
hydro dissection is best to be avoided. Maybe a hydro delineation could have been done. A question to Namrata or Dr. Ramurthy. When would you do an IOL implantation in the first instance, and when would you think of doing it as a secondary procedure?
So I think, Dr. Ramamurthy, you take it.
नहीं मैडम आप पहले
Then I'll say I agree with Dr. Ramamurthy.
No, I meant in a traumatic cataract, when not in this particular scenario. What I meant was, if there was a PC tear too in that kind of a setting and a corneal tear repair, and you needed to do a traumatic cataract surgery, probably in that kind of an extreme setting, you would do a corneal tear repair, deal with the cataractus lens, and not do anyway. You can't place the lens in the thing. Maybe would you in that kind of a scenario wait for the eye to become quiet, do the biometry, and then do a secondary IOL is what I was asking.
So Chitra, you've really answered that question very well. We would exactly do what you are saying.
I think
and Ramamurthy agrees.
Not an expert panel to deal with.
No, but I think very rightly said. We would first do the repair. Here it was a small tear. CDLs was negative, and Dr. ANJUM was very lucky to have gotten away without having to address the astigmatism that may have arisen because of that. But I think that is the way. What customarily, we would do: first repair it, wait for some time, and wait for cornea to stabilize, then calculate the alpar, and then do intraocular lens implantation.
Yes.
I just have a small comment to make. I don't think this corneal tear really needed to be sutured. I think it has self-sealed. He said his seal is negative, and I noticed that his bottle height was 60 centimeters, which means IOP of almost 40 in the chamber. In spite of it, it was quite a stable chamber. There was no fluid spurting out. It was well healed. So maybe you could have not even sutured that, and still it would have, the patient would have done quite.
Maybe just glued it also. Maybe just glued it prophylactically.
Yeah.
Sir, I applied the suture to avoid the post-operative astigmatism.
Post-operative astigmatism on
Yeah, central part would that have, I mean,
central part might have left it like that.
So anyway, the result was good in the end, 20 by 20. So
yeah. Dr. Merle, would you have thought differently in this kind of a corneal situation?
No, like Namrata said, I agree with everybody.
Oh, okay.
No, but I think one point actually, particularly if you have children with traumatic cataract and a corneal tear, I think those are the instances where we might actually operate them sooner rather than later, because I've noticed that if you allow them to wait for too long with a traumatic cataract, it tends to get absorbed. Then your anterior capsule and posterior capsule fuse, and then you're stuck and not able to put an IOL in the bag, which is extremely important in kids. Yes. So that's the only point that I wanted to share.
Yes, very relevant. I think that was a wonderful video you showed, Dr. ANJUM, and a lot of learning came out.